welcome everybody to our community meeting. My name is Kelly Kaiser, and I'm with the IHN CCO. And first of all, I would like to ask Manny to say a few words in case anybody in the audience needs some translation. Do you want to use the mic?
Buenas tardes a todos que hablan español a esta reunión de la aseguranza IHN CCO. Si necesita servicios en español, un intérprete, por favor, levante sus manos ahorita para ayudarles. No tenemos nadie. Muchas gracias.
All right. So first of all, I wanted to thank you all for coming. As a reminder, we do these meetings 3 times a year, one in each county, so that we make sure we have an opportunity to hear back from the community, how things are going around the IHN CCO, and then the community is able to hear from 3 of our board members on their perspectives on how things are going. So that's kind of what we're here for tonight. I get the opportunity to kick it off and just give some updates on how things are going and where we are in the last 6 to 8 months. As a reminder, we do video these, and they are on our website, so that if you aren't able to make one in Linn County or Lincoln County, you're able to see what information is shared so that we can try and be as transparent and get all the information out there that we can. So they're on the website if you would like to go back and look at prior meetings. They're there. I wanted to start by, we were in a meeting this morning and somebody said to me, so what are you feeling good about and what are you going to talk about tonight? And it was a good trigger to think about, starting with the positives and all the great things that have happened. And I think I'd like to start by talking about the IHN CCO really being a community effort, and all of the stakeholders involved, and the value that brings to us all working together every day, and more importantly to the members we serve. I think as I go to different meetings around the state and hear how different CCOs are doing, I'm always very pleased to hear how the perception and the perspective from outside our community is that we as a community are doing a good job of working together and collaborating. Doesn't mean it's always easy or it always works perfectly the first time, but we're continuing to collaborate and communicate. And so I think that would be one of the things that I'm most proud of around our CCO, and all of the collaboration with all of the stakeholders and partners and members that we're involved with. So I just wanted to share that. We've done some pretty significant things have happened in the last 6 months or so. We did turn in an updated transformation plan, which is available and out there, and talking around what we're doing as it relates to transformation. We've got some really good work going on evaluating our pilots. We've talked about the pilots here over the years in these meetings that we as the CCO are doing to transform healthcare, and using different pilots in each community to do that. So we have a great evaluation process going on with that. We have those pilots tying into our Community Health Improvement Plan, which I'm sure Dr. Eby will touch on when he talks about the Community Advisory Council. We also have them tied together with our quality metrics, which is another important piece. And how do we tie all those pieces together and try and find commonality so that the energy that everybody's putting into improving continues to work collaboratively as we move forward. So those are good things. I think there's been a lot of changes at the state, at the Oregon Health Authority. I'm sure you all know that we have a different governor than the last time we were here. So a lot of changes are happening, and I think those are that we're moving forward. And from the CCO perspective, I get asked that a lot. What does that mean for the Oregon Health Plan or for the CCO? And from our perspective at this point, things are moving forward very well, and the vision and the support for the CCO model continues to be there under Governor Brown. So we're happy about that moving forward and look forward to that continued relationship growing. There's some different changes in terms of innovation that we're working on as it relates to mental health and behavioral health. And a lot of those are again, out on our website as they relate to our transformation plan and looking at those pieces. But a lot of energy happening. We're in our 3rd year, so that's a pretty big deal. We started in August of 2012, so we're coming upon our 3rd year anniversary of the CCO. And I think, it's interesting to see how long certain things take. Some things go really fast and are figured out very quickly, and then some things take a little bit longer, and we try something and it doesn't quite work, so we try something again. And I think the beauty of our partnership with our community partners and our stakeholders is what's allowed us to be successful and continue to change and move forward. So from my perspective, I think those are all really good things that I'm proud to share. And I know you don't want to listen to me all night. And so I'm going to turn it over to Commissioner Dixon So our approach tonight will be to hear from each of our board members on their perspective, a little bit of a different perspective from each of them on how things are going. And then we'll have more of a community discussion, so we make sure we hear back from you on how things are going and what the opportunities are for us to improve. So, Commissioner Dixon, you want to be first?
No, but I will be.
Okay, would you be first, please? You can stay there or go up there, whatever works for you. We have mics everywhere.
Well,
Hold that one down to it.
since we decided that this meeting should be casual, probably we should do that from here rather than from up there.
There we go.
So, thank you. For those of you interested in trivia, interestingly enough, I started the day with a meeting as well in this very room. So, meeting with two groups of middle school students in a 4-H program, and they were learning about county government in Benton County. I can't imagine that they were thrilled with that topic necessarily, but I think they were excited when the district attorney put on his act, and I think they got a chance to tour the jail as well, which usually takes the interest up a notch or two. Well, the progress made by the health departments of all 3 counties and the IHN CCO can be best illustrated in a couple of different ways. I said at the last meeting of this group, and it was hard for me to imagine that was a year ago, but I said that I really rely upon our health department to tell me how things are working. And if they're happy with the way things are going, then we are happy with the way things are going. In an April 5th article in the Corvallis Gazette-Times, managing editor Mike McAnally quoted our health folks who said, "The Coordinated Care Organization has paved the way for nearly 24 joint projects between the counties, all based on key areas: access to health care, behavioral health care, chronic disease care, and maternal and child health." Linn County Health Director Frank Moore, who is here, where are you, Frank? Right back there, was quoted, and you can tell us if the quote was correct, was quoted as saying that never would have happened prior to this, and this was the IHN CCO. So early in this process, some folks were concerned that the IHN CCO would take over healthcare and leave out the counties. Instead, there's developed a strong collaborative partnership between the counties and the IHN CCO. Consider what happened at the Benton County Health Department National Public Health Week event a few days ago. A special Public Health Innovation Award was presented to Kelly Kaiser, Kim Whitley, Dr. Kevin Ubanchawa, Jenna Bates, and Megan Mackey, key players in the IHN CCO organization, for what was described as groundbreaking efforts to create new partnerships with public health programs aimed at enhancing preventive health management and avoiding illness. And I know that even though the award was presented to those folks who are the leadership, a lot of other people in the IHN CCO contributed to that. Most recently, we've had the opportunity to partner with the CCO in a pilot of an alternative payment plan for primary care services. This supports the continued transformation of the county's health clinics and supports our efforts to enlist more residents of the county in proactive health care. So we've come a long way in the last couple of years.
Like to give us an update?
Thank you, I'll do that. And I too like this more casual format, so we'll ask for a repeat performance of this.
All right, you got it.
Just remind me in advance when I'm supposed to bring the casual shirt, so I'm not changing out in the parking lot, which I think is what I was doing coming in here, but I was happy to do that. Let me pick up on what the commissioner just said. As we approach our 36th month as an operating organization and have been involved over the years with a number of healthcare startup ventures, that's kind of an important point in time about how's the organization doing, how do we look in terms of the outcomes that we were trying to achieve, how do we look in terms of a balance sheet, in other words, do we have enough money to operate and are we sustainable going forward, and most importantly, are we achieving the goals that we had defined? And I think the short answers on most of those questions are we have and we are. So as we enter into our third year of operations, it's really hard to think about that when you look back on the past, and when I think about some of the initial questions we all had about how is this going to work, is it going to be more collaborative or is it going to be anti-collaborative or what's it going to look like, it's really worked well. And I guess what I'd like to do as the chair of IHN is to acknowledge the great work that's been done by multiple parties across community spectrums, both from the volunteer lay leader side to the actual healthcare professionals and those people that provide care. I think some great work is being done. And while it certainly is nice, and I second the recognitions that are coming back to us now, I think probably the most important thing is the impact we're having on patient outcomes and patient care. And if you really kind of dig down into the data to say, well, what are we doing? Have we launched new initiatives? Have we really impacted community groups that previously maybe were not having as great of access to care? Have we really started to make a change in population health, which is kind of the term we use for saying, how is everybody doing? I think, again, the answer there is yes, we have. Now, we got a lot of work ahead of us, but comparatively, when you look at where we're at, when you look at where the rest of the CCO operations are in the state, and I might even suggest to you, even on a national scale basis, I think this model, in large part because of the cooperation and the collaboration amongst parties, has really achieved some very good outcomes moving forward. The other thing, certainly, you look at with any new venture going forward is it sustainable during periods of uncertainty and chaos, if you will? Well, we kind of have one of those recently, and the good news there again is I think the operating parts to the organization have worked very well. I think the interface with our partners, both at the local, regional, county, and state level, have worked very well. And so I feel good about the future for us. And again, in looking at the context of things in terms of the state and its budget process, and the legislative process, and the funding mechanisms, and all those types of things, I think we feel pretty good. And I'm confident our new governor will continue to lead us in a positive direction of continuing to focus on population health, of continuing to carry out the mission we have started, because it is that important. And I know, having had an opportunity to talk in other states around the country over the course of time about what we're doing here, what they'd like to do there, how they might like to do it and such, what we're doing is noteworthy. A lot of other states are kind of going through a process. Well, how can they kind of try to do that? They might do it in a little bit different way or version, but I think our model has demonstrated the kind of outcomes that are sustainable for the future. So I guess, Kelly, as we sit here going into our third year, I want to compliment you and the staff certainly for the good work, the great work that's been done. I want to thank all of our provider partners out there, private sector, county sector, all sectors, for really working with us to try to make this thing go forward, and just say, well done, and let's keep doing it.
Great. Thank you. All right, Dr. Eby, the chair of our Community Advisory Council. I think he's going up to the podium.
Yeah, is this working? Yeah. When I was younger, I was afraid to be different, but at my age, what is there to lose? Actually, the main reason I got up to stand up was that there's some short people in the back row that can't see me if I'm sitting down, so for the benefit of Stretch back there, here I am, Stretch, pay attention, you can see me.
Yeah, it comes with age, that's why you gotta stand up. Right?
Yeah, I know. Did any of you in the last, I don't know if it's 2, 3, 4 weeks, see a program on healthcare that cited different places around the world, I think, but also a major segment on the Alaska Native Medical Center? Anybody see it? Then my punchline isn't going to work.
Try it anyway.
I'll try it anyway. Well, I am told, and unfortunately I didn't know it was coming on, and I've tried to find it since, and I can't find it online. They said, we saw your son on TV last week. Well, actually, that wasn't my son. That's a 25-year-old program, and that was me. Dick, if you saw it, I'm sure you know. I'm sure you recognize that was me and not my son in that program.
Nice try.
Let's see. Did they have TV back then? I don't know. Anyway, that guy was taller, but then in the intervening years, I have shrunk some too. So who knows who that was? It was a Dr. Eby. And I won't brag about what's happening in Alaska and what he has to do with now, but if you want to hear about it afterwards, I will tell you. And in fact, in June, Mary Jane and my wife, who's right here, Doug's mother, and I are going up, and I hope he's going to get me into it without having to pay the regular price I'd like to take. They have a very good 5-day program up there that outlines the things that they have done in terms of primary care, and it is astounding. I can tell you how to find a lot about it. In fact, just look up the 4 letters NUKA, and you'll learn a lot. That's not what you came to hear about, unfortunately, so I'll go into what I'm supposed to talk about. Yeah, I represent the Consumer Advisory Council for the region of Benton, Linn, and Lincoln counties. We are a 19-member panel. I'm going to tell you a lot of things you already know, but some of you might not know it, so I'm going to repeat it. We're a 19-member panel. The majority of us are consumers, IHN consumers, or people who have very close connection with IHN consumers. We have responsibilities, and they include identifying and advocating for preventative care practices, develop a comprehensive health assessment and community health improvement plan for the 3 county areas, reporting annually, planning and publishing a report on the progress of that community health improvement plan. And in order to fill those duties, our CAC representatives are committed to becoming familiar with the general healthcare plan of the CCO structure. We together advise the IHN CCO regarding strategies for engaging and educating the community. We are to advise them on the healthcare needs and concerns of the population, particularly the IHN CCO consumers. And we are also to advise them regarding the system's ability to engage and activate the members, the IHN CCO members, as full partners in their treatment. And this is something that's come with the medical home model, the patient-centered primary care home model, where patient involvement in their care is the big emphasis and is crucial to making it work. I was at a meeting today at Albany Hospital where the discussion was on the difficult or the angry patient, and it was quite illuminating to me. But as I sat there and listened to it, I thought, this is what we're challenged with in healthcare in terms of involving the client in their care, and sometimes they get angry because we don't have all the answers for them and are trying to involve them in their care, and so it's up to the caregivers to develop a relationship, and that is what is so nice about the new emphasis on the patient-centered primary care home model. We are to proactively engage the community to be involved in the issues, and so that's why we're here tonight, to engage you, and we are continually looking for more ways to do that. Now, just a little bit about the CHIP, the Community Health Improvement Plan. This was put together approximately a little over a year ago, Rebecca, that we finally wrote it. It went through the process of being approved by it was put together. Well, first of all, it was started by diligent work, hard work, tedious work, excellent work by the county advisory committees. Each county, Benton, Lincoln, and Linn, have an advisory committee. They meet some once a month for a longer time and some twice a month for a shorter time. And it was amazing the work that they did to put together, first of all, a health assessment and then the improvement plan. Now, in those plans, in that plan, there are 4 areas of emphasis: access, behavioral health, communicable diseases, and maternal and child health. So there were goals. There were something like 14 goals, 13, 14 goals.
45.
Goals?
Oh, activities, you're right.
Yeah.
Eight goals.
Only 8, anyway. A number of goals and those goals are in place for 3 years. Now, we look at those goals and we may reinterpret them, but we don't throw them away and get new ones during those 3 years, because if we've done good work at the beginning, then we feel our best tool to do our task is to stick with those. But the next step then was to define, and we wrestled with this a lot, and I have to give Mitch Anderson credit. For one day he said, well, suppose you look at your goals and you say, okay, if you met that goal, what would it look like? And that just sort of opened it up, and that's the question we've been asking since. And we are doing this in the 3 counties in these 4 different areas of access, behavioral, chronic, and maternal and child health. And for each one of our goals, we are saying what it would look like. So, just an example, in access, our first goal was to ensure adequate provider capacity for primary care, dental health, mental health, and substance use for IHN CCO members. I'm going to read that again. Ensure adequate provider capacity for primary care, dental care, mental health, and substance use for IHN CCO members. Now I'm going to read to you, we did brainstorming. In each county we did brainstorming. And so using this question, what would it look like? There was brainstorming done, and this is what Benton County said about this access. This is what this is what it would look like if we ensured this provider capacity. There would be timeliness of appointments. The persons would receive appropriate treatment in the appropriate location and appropriate level of care. There would be more providers trained in equity and cultural diversity. There would be an increase in availability of multilingual staff, interpreters and communicators. There would be a streamlined process for developing and editing educational or instructional materials with a focus on health literacy and cultural sensitivity. There would be a reduction in appointment time. There would be an improvement in satisfaction. There would be an increased availability of providers, and there would be an increase in weekend hours. Now, this is a long laundry list. This is a brainstorm of what it would look like. And now we are working at which one of these are doable and how would we do them. And so we're going to be paying some attention to outcomes. And so, for instance, outcomes for these might be an increase in the percentage of members who receive appropriate care at the appropriate time and place. That would be an outcome that we'd like to see. And indicator of this, and this is down the road somewhat, is we will be looking at this. We say we put these indicators. We have an indicator parking lot that we're working with. And so an indicator might be that the time of enrollment from the first appointment, the time from enrollment to the first of appointment as a measuring stick, and the time for request from appointment to the appointment time. So this I know it was rapid and sometimes garbled in my way of presenting it, but I wanted you to kind of understand that there is a lot going on. We are convinced that it's, most of the time, that it's meaningful work. It's as meaningful as what we have the imagination to make it, I believe. Some of our challenges are on both the local county level, county advisory council, committee level, and the regional activity, regional advisory council level, is to keep members. People have a lot on their plate, and especially our IHN consumers have a lot on their plate. And it's very difficult for them to sometimes to keep up the commitment. So we've had more turnover and more vacancies than we'd like. The second thing is, and I want to just mention something that they're trying to do in Linn County, and that is how do we connect with and how do we get feedback from the consumers, other than through the committee channels. And so Jessica Hiddleston, who is a active member of the Linn County Local Committee and works in the health equity.
Willamette Neighborhood Housing Services and Health Equity Alliance.
Would you say that again louder?
Yes, she is a resident services provider at Willamette Neighborhood Housing Services and also helps coordinate Linn, Benton Health Equity Alliance.
Yeah, and so she's, yeah, thank you. And so she has connections with a lot of people who are IHN consumers. And so for in the next 2 weeks, she's going to have 2 meetings, one in Sweet Home and one in Albany, to try to get more of these people, of the consumers, IHN consumers, in and hear what their concerns and interests are. So we're really looking forward to that, and if it works, Linn County is going to be kind of a leader in this, because I'm part of webinars statewide for chairs and vice chairs of CACs, and that's something everyone's wrestling with and no one's doing too well with. So that's as much as you wanted to hear, and I hope I stirred a little interest in you in what we're doing.
So along those lines, I know we have a number of members here who are on the Community Advisory Council. Could you raise your hands if you're on the Community Advisory Council? See all those great hands? So if you have questions or feedback, and Dr. Eby, of course, they have little name tags. And then we also have a number of people here who are on the board. Could you raise your hands? Raise your hand. You're on hold. Very good. So we just wanted to make sure you saw and they have name tags on so you can track them down. So we really wanted to make sure we left a significant amount of time to be able to hear from you. And given the brief information you've gotten over the last half an hour, are there any, is there some feedback from all of you on how things are going that you would like us all to hear that we could respond to? There we go. Oh, it's coming to you.
My name is Dick Gold, and I live in Corvallis, and have only lived here about 3 years. And I've become very much interested in what you're doing, what the other CCOs around the state are doing, and I'm very happy with the increased enrollment with people who need health care in the last 18, 20 months. I guess I was sort of totally shocked to learn that an outside corporation, one of the very large ones that operates in, I think, 20 or more states, would come in and suddenly purchase, I guess purchase more than just the CCO in Lane County. But I guess I'm wondering, how is that possible that this comparable analogous kind of organization in Lane County is now more Aye.
Using your mic. That's one. So you have it. Oh, she didn't know.
Finish your question.
Well, just that the organization that is in some ways analogous and comparable and somewhat supported by the state is now imminently. I'm not sure that, well, first of all, there has been absolutely no public information, no disclosure as to dollars involved in the purchase and who gets it and why and so on. But I don't want to ask you to necessarily comment on the Lane County situation, but how is it possible or not possible that I could wake up and read the similar kind of story in our local newspaper?
Great question.
And what does transparency mean, which I read in almost every single document, every single report that describes this transformation? I read something about transparency, and yet there is really no transparency with respect to what is going on in that circumstance. So I don't blame you for that. I don't, I just am fearful that I'll wake up and find a comparable circumstance from my friends who are enrolled here. Thank you.
Well, thank you. If you don't mind, Kelly, I'll take a shot at it. I think the observation you're making, and for those of you not as aware of it, at one of the CCOs in another part of the state, they did get acquired by an out-of-state for-profit organization, I believe, to operate their activity. And actually, one of the reasons we set up IHN CCO as we did was because we're not of the same type of model as they might have been. So in other CCO models, you might have individual groups that are owning or controlling the activities of those CCOs. And I think one of the things we intentionally did going into this was, first off, it was based with a nonprofit organization, so we already had community representation at the Samaritan Health Board, if you will. And then as we composed to the structure of the corporation itself, we brought in all, or as many of our partners as we could. And I think that's really what makes the difference about how do those things happen and whether anybody's aware of them and so forth. When they talk about transparency, they're talking about a lot of different things. But I think what's more important is, if you will, how the representation works. And so it's hard for me to envision, quite literally, that you'd wake up one morning, to your point, and you'd say, we sold it without everybody knowing about it, because just about all the different constituencies that we represent, both in the public sector, the private sector, the nonprofit sector, the insurance sector, are there together. And I think where you're more likely to see events like that, and I would choose not to comment on it, because that's not my role to comment on how others have done what they've done or will do. But in part, we set it up this way intentionally. And when I was remarking earlier about how pleased I was going into our third year of operations as to how well it has worked, that doesn't mean it has worked without a lot of deliberation, a lot of debate, and sometimes contentious issues about who is going to do what, how are we going to cover the spectrum of the different services that we have to cover, how do we make sure that everybody is receiving the care that they need. When you heard Dr. Eby's report earlier from the advisory committees, there's a lot of people involved in this process. And I think that's really the transparency that we should be looking for. And I think it's fair to say, although again, I haven't studied each of the other CCOs, that each is kind of designed the way it organically came together. It's interesting, your question is stated as it is, because I just got asked to sit on a panel nationally to defend why I felt hospitals were still relevant in the current healthcare model going forward, as opposed to having others just take over those activities, albeit whether they were insurance companies or home health agencies or whatever they might be. And part of the argument I would make is the same I would make here, because your community-based hospitals, your nonprofit organizations are the community for the largest part. If you look at the composition of our boards, either for the CCO here or for the parent, the member corporation that does this, nobody's a shareholder. In other words, one thing that can't happen here, nobody's gonna make a whole lot of money selling anything, because none of us have a position to make a whole lot of money if it were to occur. If we were held by an individual group of people, or if we were individual shareholders or investors, then that might not be the circumstance. But I think a key element is how you were structured going in. So I think we can say to you, Dick, that you're pretty comfortable that we're not gonna discontinue business because of an event like that. What's a more likely threat to us is continued funding as we go forward. One of the reasons I made the comment I did about the governor and the state and the rest of it is that's probably the more relevant question that we need to get comfortable with, is how do we sustain our operations as we go forward, as we get deeper and deeper into a population health-based model. And will we have, even though right now it looks pretty good, will we have adequate funding to ensure that we can keep all the providers there? Will we have adequate funding to grow the base of programs and services to meet the other needs, albeit whether they're mental health or dental services or educational services, whatever they might be. But again, the good news I can report to you is we got a whole lot of people talking about it. So that's where I think you can take some comfort that the likelihood we're gonna have a fire sale or a sale in the quiet of night just wouldn't happen. I mean, for one thing, I'd have to be, all the people you see up here, one of the reasons we do come before you as a public group to say, if you got a question, ask us. If we were a tightly held private corporation that wasn't community-based, did not have mission ahead of margin, then you see things like that happen. And I talked to some of the people who are involved in that transaction, and I have an understanding why they did what they did, but, and I'll look over at Kelly, and I don't see that happening here. I mean, it's just not likely. I wouldn't say anything's impossible in today's healthcare environment, but I don't think it's likely to happen, Dick. And in part because of the way we structured it, not even so much the transparency, because if somebody wants something to happen, I don't care how transparent you ask them to be, if it doesn't really operate as that kind of an organization, it's not gonna make a difference. So I don't know if that helps maybe to understand, and if everybody really appreciated what it is we're talking about that just happened. But yeah, a lot of us looked at it and went, wow, that's I don't want to say an intrusion, but that's an entry into the state market area that's not been there. And just on a personal basis, that's one of the things I would resist quite strongly, because I'm very much a believer in a community-based advocacy type model. Not that the for-profits can't do good things, not that private ownership doesn't work. I'm a free market advocate as well. So I mean, I certainly support that, but I think for the kind of mission we're doing, this is the right model.
Great question.
Yeah, great question.
Another question?
Mine was on the same lines.
Here, let's get the mic so we can.
My question was going to be on the same lines, and just the further question is, do they think that there's a profit to be made off of owning a CCO? I mean,
Well,
isn't the money supposed to be spent on
I think you
members?
to recognize the company that did this is a national company that manages Medicaid plans around the nation. So Centene is a company that this is what they do. So I would imagine it's because it's within their scope of what they do that they believe they can be successful at it. Certainly, I don't know anything about the specifics of what that would mean.
Well, I'll go a little bit deeper than that, but not much. I think there are companies out there that absolutely do believe that there's margins, that there's profitability to come out of population health. But it's like anything else. It's what are you doing? If anybody was to get into that model, and I'm not saying that this is what they're doing, so especially since we're being recorded, I'm sure they have honorable intentions, and I'm not disparaging, what they're trying to do or how they're doing it. But there's a lot of companies, that's how they make margins. They manage populations, and then they provide care and services, and some of them do a very good job of it, and they end up with a margin. the major difference here is, again, we don't have shareholders to pay. We don't have stockholders to make earnings reports to, if you will. Now, even with that, we gotta be sustainable. So again, when I talk about the balance sheet, people, what I'm really saying is, not just do we have enough money this month to do what we're doing, but we're making a lot of promises organizationally to the general population. Now, some of that we're doing because we're compelled to do it, because somebody's saying to us, this is what you gotta do to be a coordinated care organization, or to be a population health-based organization. But one of the things we have to remember is when we make those kind of promises, we have to carry them out over a period of time. And so for a lot of organizations that they're in that space, in other words, they either deal with Medicare products or Medicaid products or population health-based products, yeah, they think they can do it. And I think we can learn from them. I think there are, lessons we can learn from how they manage service lines, how they do certain things that they do that we can incorporate into our model to make us stronger, but not with the idea in mind that we're just trying to drive earnings up or create dividends or margins so that we can have higher ratios to sell it for. Yeah, I think that the biggest threat to us, honestly, as an organization, is if we didn't have adequate funding to fulfill the promises and all of that, then either we're gonna be looking for a partner to help us keep those promises, or somebody's gonna come in and say, get a partner to keep those promises. Does that help you?
Nope. Lots of hands.
You've expressed some, what I would say, considerable optimism about how transformation is going to continue under the new governor. I listened to her State of the State speech last week, though, and unless I'm simply not recalling, I don't recall her mentioning healthcare transformation in the entire speech, despite the fact that it's probably one of the most exciting and important things that's going on in Oregon. Can you tell us, or can you help us understand the basis then for your optimism about how this is going to continue?
So from my perspective, we work very closely with Linn Saxton, who has just been appointed as the director of the Oregon Health Authority, and have met with her for many, many, many meetings over the last 2 or 3 months. And the feedback we're getting from her, as she was hired, or she was originally appointed by Governor Kitzhaber, or slated to be appointed, and then her appointment was held off in the midst of the change, and then Governor Brown did put her name back in, and she was appointed as the director. And the feedback we're getting from her is the feedback basically from the governor of her continuing to do the changes she's looking at doing, working on the path that she had set out, and keeping on the same path. So I would say my optimism comes from that feedback of what she's been directed to do and supported to do that transcends to all of us to carry that out, has been very supportive and continues down the same path we have been on. So that's where mine comes from.
I would just second that. She and I have not had a conversation specific to coordinated care, but I believe that she's going to continue with the programs as they are now. We'll have to wait and see how long in the future that continues, but I have no reason to believe that anything is going to change abruptly.
No, it's a great question. If we can continue on to it for one more minute. I guess my optimism rests in the fact that I haven't seen any negative actions or events since the transition has occurred. And knowing that the new governor was stepping into a position where the prior governor certainly had ownership of this kind of model, I think that's a good sign. That they just didn't go in there and say, okay, we're gonna stop this or do that or do the other. And from what I know of the governor, and I don't know her personally enough to comment on it, my understanding is, though, that she's an insightful person and she can see where value is being generated for her citizens, and I would assume would support that. This state, has made a big bet, if you will, on healthcare reform and transformation. Probably one of the largest that you're going to find proportionately out there. So I think it would be a real reversal of fortunes to pull back from that. It's kind of like we're into this process. We kind of got to see it through. And for a number of us literally sitting around our table too. There was a lot of debate about, should we? Is this something that we felt as an organization that we wanted to put our balance sheet at risk and our reputation on to say, hey, we can pull these groups together and make this work. So when you make that kind of commitment, it kind of rises above, the partisan politic issues and other things and says what's really important here. And I'd be very surprised, I wouldn't say impossible again, to see a reversal of that. Now, there's other legislation in the state, if you want to talk about it, I can give you a different opinion on. But I think as far as where we're at and what we're doing, we're probably okay.
My question is kind of in the same vein, but perhaps at a different level. And one of the things that's just been fascinating about this whole experience is, you've got things going on at the local level, the county level, the regional level, the state level, the federal level. It's hard to know which level to exactly focus in on. But I guess I want to ask your thoughts on perhaps the federal level. In my understanding, and by the way, all of us here are a little cluster of members of the Benton County Citizens Advisory Council, and I understand that the federal government has made the commitment to do most, if not all, of the first 3 years of funding for the expansion of Medicaid within each of the states that are signing on to it. I know you guys are coming up with your 3-year anniversary here later this summer, but I think the 3-year window we're really talking about with the federal government is the calendar years 2014, 2015, 2016. And so we're coming up to about the halfway mark of that 3-year window. Granted, we all know that with both houses of Congress being controlled by Republicans now, the attacks, the criticisms, the efforts to undo all of this are only being more intensified. And it remains to be seen, whether this will even survive the first 3-year window. But I guess part of what I'm confused about, and I don't know if any of you can help shed light on this, is what's expected to happen either at the state level, at the regional level, at the county level, when this first 3-year window runs out. I mean, we're trying to put new mechanisms in place to get new revenue streams coming in different directions, and I don't know if we're going to have to consider starting to actually charge for fees for services for OHP members after this first 3-year window is up. I mean, what are your strategies? What are your fears about what's going to happen after this 3-year window kind of flies by and we get through that? And maybe that you just made a reference. Maybe there's some things that the Oregon State Legislature are trying to do to ensure funding streams and ensure, the overall enforcement of this new system that we're still in the very early stages of creating. I mean, it certainly feels like it's up and walking right now, but something still needs to hold its hand, it seems like. So it's still kind of in the early stages. So I hope that's a clear enough question that you can generate some ideas to.
Well, I can take a stab at it to start. I think, to be honest, I think that everybody's been so focused on making sure we take care of what's in front of us today that's really been where a lot of the energy is, with the understanding of where we are in terms of the time frame and how it relates to whether Oregon has its separate waivers that are different. The CCO waiver is a separate piece that related to the expansion population, which is that other piece. So how all those pieces fit together from the funding streams in terms of longevity is something that we need to understand and look at and be part of. But I don't have a great sense from the federal perspective on how those pieces are all coming together. I haven't been involved in a lot of discussions around that at this point yet. I think because we're just up and walking, but certainly that's something that we need to be aware of and be involved in. Not much of an answer, but it's part of an answer. Anybody else have more insights?
Well, your question, like the ones that preceded that, I think are very insightful. That we all know there's a lot of activity going on, particularly as it relates to funding healthcare reform, state and federal legislative actions. And what I'm hopeful for is, again, on a bipartisan basis, and I really think we have to approach it that way, that the common sense will prevail, that if we have a good program model and it's in the public's interest, then at the end of the day, when all the partisanship, all the politics get done, we'll have a sustainable model to work with. What I get more concerned about at a state legislative level, though, is that if the system, the delivery system or the underwriting systems get overwhelmed because of all the different agendas on there. I was taking a quick look before we started our meeting, and I must have been contacted on a half dozen pieces of legislation that are pending, coming out of sitting committee of this, that, and the other, and asking what's our thinking on it. And I guess one of my thoughts is let's approach this in a way that makes some sense, because if we try to change up everything too much, too fast, too heavy, then we run a greater risk. And if there's anything I've learned over the years in business enterprises, it's that you have a risk tolerance level that you can sustain fairly well, but if you overwhelm it, you really run a risk that you won't be able to sustain the tolerance. And so with all the different changes happening at once, and you have to appreciate that, there's a cost to be borne, whether it's a regulatory perspective, it's a financial change, it's a political initiative or agenda to everything that's going on. And it seems like everybody has an opinion about healthcare. I'm okay with that. But we need to be thoughtful as to what we're doing. Now, the federal side, I don't know. I think we'll do our best to advocate for it, but what's most important for us to do is what we've done, build a model that is sustainable and that we can modify if we need to. Now, I'm certainly not going to speculate what we might have to do in the future to maintain operations, but what I would hope we can do is if we need to implement something to maintain operations, we have the will and the courage to move it in that direction, knowing that there's all kinds of different constituencies that will be happy or are unhappy about a lot of different things. But it's a complex field we're in, but I think we got enough good people in this room and around the different board tables and other tables that we'll come up with the right decisions.
Other questions? Oh, Stretch.
Oh, I'm a little simple guy, and Kelly and Rebecca's heard me say this before, time and time again. You say it's going to get done, or it has been done. What has been done? When are you going to put it set in stone? Talk is talk. When is it actually done? When do we actually see it? Not sitting there, you sit around and you're talking and talking and talking. Well, we done this. Well, I haven't seen anything done. When does it actually get done? I can see it in stone, like the Bible.
So I love that question, Stretch. So part of our challenge is that there are many things that have been done. I can name off a few of them, but they're not necessarily concrete, right? Because what we're dealing with is with people and human beings and changing behaviors of the delivery system, of the providers, of the members, of the way things work. So there are a number of things that have been done. I think a simple thing we could say would be that the majority of our members on the IHN CCO are enrolled in a patient-centered primary care home that has been approved by the state. So there's kind of a simple thing that has been done. It's not done just because of the IHN CCO. It's done because of the direction of reform and the community and all working together. But that's not necessarily something that you see. It's not in stone. It's not the Bible. But I do think that there's many things like that from a systematic change that we've been able to accomplish. And I think as these things don't happen overnight, so there's it's a long lead time. I think back to the community health improvement plan being a 3 to 5 year process. All of these things take time to happen. So we have done some things, and I'd be happy to sit down and go through those with you. But not very many of them are concrete things that you can put out on a banner. You're right, because a lot of them are inherent in the way things happen, and we're changing slowly how some of those things happen to happen in a different way. And so it is a process.
The main reason I said that, Kelly, was, there might be folks in here that are a little afraid to speak out.
Okay.
You know me, I ain't afraid to speak out, speak my
Excellent.
opinion at any time.
I appreciate you leading that question in, and I'm ready. Okay.
Well, Kelly, I would differ with you slightly. I think there are things you can point to that are done, but to your point, I think it's never done. This is an ongoing transformational process. And if you look at the work we're doing, the work that's been done with healthcare, it's constantly changing up. And so it will never be totally done. We'll be constantly revisiting the models, we'll be revisiting the outcomes, we'll be measuring things as we go forward, we'll be getting input from the community about are we doing the right job, are we not doing the right job, and we'll change it, and that's what you want us to do. What's not sustainable is a steady state. In other words, if we said, okay, this is it, and never more will we change it, that won't work, I can guarantee you that. Because especially for those who have been around healthcare for a while, it's never a steady state. It's constantly changing, whether it's the types of drugs that we're using, or whether it's the treatment modalities, or it's the reimbursement mechanisms, or it's the organizational structure, or it's the population health-based activities, where I think we can do a lot more work than we have done and will do, is especially in the areas that are new challenges to us, mental health and dental services. I think those are a couple of our biggest opportunities to have a tremendous impact on the people we care for and the populations. And I was just thinking back to just a few months ago, Frank and a few of us were in a presentation where we were talking about the state of mental health. Actually, we were talking about suicide prevention and some other things. And Frank was there kind of representing county mental health and in its perspective. We had another gentleman there representing the Veterans Administration, and we had a third person that was there representing kind of a suicide prevention organization statewide. But the thing I felt the best about was we really had a lot of different parties talking with each other, trying to get some cross models, if you will, for how we're going to prevent something going forward that has tragic occurrences if it happens. And I think some real good came out of that. Well, pre-CCO time, it may or may not have happened, but we just didn't have the connectivity. And with the connectivity we have now, therein lies our greatest opportunity. But I think it's never done. We'll be, I don't know if I'll be sitting here, but some years from now, others will be sitting in front of groups like this saying, okay, what's the next big thing? What's the next issue? And if you look at our society right now, especially what are the headlines telling us? Well, we got a lot of things that we're watching, pathogens, microorganisms. How do we handle that? How do we handle mass population health-based models when it comes to immunizations, when it comes to a lot of stuff? So our work's just beginning, but I'm excited about it. I hope you are, Kelly.
Oh, yeah.
Yeah.
We're here. Dr. Eby, you want to comment?
These meetings have been going on now. We've been having them for about 2.5 years, I think, something like that. And the very first one that I think, at least that I participated in, was in Linn County. And Stretch, you asked the same question then that you ask now, and this is an important question. I think that all of us that came onto the regional CAC came with expectations from our own experience and what we visualized as our role and what we visualized in terms of what the CCO and the advisory council were or could be. I think we all had personal ideas of what we wanted to see happen. We had ideas in terms of our function as a council, that we were a conscience of the organization, that we were somehow supposed to be making the leadership feel guilty when they weren't doing what they were supposed to be doing, and that sometimes happened in terms of what people brought, I think. My answer to Stretch at that meeting 2.5 years ago was somewhat like I would say to any of us now, and that is, get involved with us and work together and see what we can do together. And so in the intervening 2.5 years, some people decided that they didn't want to spend their time in the processes that the organization, that the council were using to achieve the goals that they, and the duties that they were given to perform, that they would rather work at things in a different way, and so they withdrew. I'm not going to go into what those reasons were. They were varied. Others, I think all of us probably changed our mind to some extent from what we originally thought. And what have we accomplished? I think we have accomplished structurally and procedurally, and I don't know what all the words I'd want to use, all the adverbs, but with all the pilot programs that are being carried out under this organization, it's pretty fantastic, and we don't have time to go into them, but an awful lot of really, really innovative stuff is being tried. And that would never have happened except for this. I don't think. It would have been up to smaller organizations that didn't have the same interest and the same motivation that are being done now, and they're being done cooperatively. And so, yes, IHN dental people are getting dental care now that they didn't get before.
With Betty next.
I think all of us really appreciate how important quality hospital care is as one of the really absolutely essential elements in any healthcare system. And so I'm wondering if one of you would like to comment on how does Samaritan Health Services anticipate moving forward to implement the two recommendations, policy recommendations that have recently been announced by the Oregon Association of Hospitals and Health Systems, having to do with, first of all, the providing hospital care for the uninsured, and the second thing, carrying out the community benefits program.
Oh, Betty, she always asks great questions, and I was thinking when Dr. Eby was talking about the number of people who we could kind of continually count on to be there to give us good advice and counsel, and you've always been one of those people, in part because she follows this stuff. And what she's referencing right now was one of the 6 legislative questions I was asked earlier today. I'm not even an elected official, you know, so why they're telling me about these things, call the commissioner. You know, he's got more sway than I do on them. But to try to answer your question, let me construct it a little bit better for everybody else. There's a lot of legislation pending right now that relates back to the definition of community benefit. In other words, what kind of charitable work and activities do we engage in as a healthcare system? And there's Benny, I'm sorry, you said which 2 legislative pieces were you referencing? I want to make sure I got the right one.
I'm talking about legislative pieces. I'm talking about the 2 policies that the Oregon Association of Hospitals and Health Systems announced recently. The first one has to do with paying
Yeah, Benny,
for.
I'm sorry, I can't hear you.
Paying for, the first one has to do with paying for hospital care for the uninsured, and the second one has to do with how does the community benefits program continue in the future?
Do you know?
Was your first question, Betty, around the premiums? Is that because the hospital
Sorry.
association?
Well, Betty, the reason we're trying to get clarification, there's a whole bunch
I know.
of policy recommendations right now, and I can't even remember all of that, so I want to make sure I'm answering your question.
Yeah.
So you're talking about the
policies from the Oregon Association of Hospitals and Health Systems. I'm not talking about legislation.
Okay, do you know?
I don't know the specifics of those right
I-
now.
Okay.
You can certainly find out.
All right?
Let us know.
You can send me an answer by
Yeah.
email.
No, we will, Betty, and I'm not aware specifically, so I don't want to just comment off the top. But I thought you were talking about the community benefit pending legislation. Okay. Was there?
More to come.
Over here? Oh, okay, right here. And then over here.
Hi, my name's Chris Folk. I've been a nutritional advocate for quite a number of years. I'm now a peer specialist at Benton County. but I'd like to ask a question mostly in my independent role as a citizen. The major problem, I think, with the older system, which we're still in, I don't know how many feet in there, was that it made more money the worse job it did. In other words, if they applied therapies that didn't get people well or created more problems, they just get more customers and more profit. And I know the CCO was designed in good part to address that. With more global approach and results-oriented approach. And I wonder how that's going.
So I think that's a great question, and it ties very nicely into, we've talked historically at these meetings around our quality metrics. So one of the ways that the state set up the coordinated care organizations are around the funding and the global budget that's in the funding, and part of that is set into a different pot related to quality metrics, and each CCO has to meet those quality metrics in order to get that funding back. So it changes the dynamic a little bit and creates different incentives at different places to encourage the outcomes. And really it's that main focus as it relates to the triple aim, as we've also talked about around, access, quality, and cost, and making sure satisfaction and access are available at the same time as quality and cost, and how you balance all three of those things at the same time. And so I think the way that the funding is set up to encourage that quality outcome, because that's a financial benefit, and that only happens if you do it right and focus on that. So this is just coming out with our second year results on those. We'll be coming out in the next couple months to see how we did. So that's another, again, in year 3, we're getting into all those pieces, but I think that's one of the approaches that the program is set up to do, is to really to try and tie those.
One specific question. When you say quality, what do you mean?
So there's 33 quality metrics that the state of Oregon has agreed to with the federal government in order to get these waivers. About 17 of them are in our contract with the state to say we will deliver on. And if we, as the CCO, deliver on those, then we get additional dollars that were not part of our global budget before. So they're incentivizing all of us to do it right and to have the quality outcomes, not to just pay fee for service or pay for the service.
There's a lot going on.
So there's a lot going on, absolutely. But that's a great question.
At the statewide meetings in Portland in November, December, one of the plenary speakers there said, don't let the quality metrics that just pay you more drive everything you do, but rather have other things also. And so that's what the Community Health Improvement Plan is all about. It's to incorporate some of these other additional ideas that really come out of the community. They don't come from what the state mandates. They come from what the people mandate through the representatives on the committee, on the 3 committees. I want to say something a little bit aside because it's what I talked about before, and that is I didn't realize that on this sheet of paper that you got about events, that the first 2 events there are what I referred to as what's happening in Linn County. And this is fairly self-explanatory. I want to point out to you that this is inviting you to participate and to register for the free dinner. But one thing we don't want it to be is just the choir there. We're hoping that the vast majority of the people there will be people that aren't in this room, and maybe not in the county, at the Linn County Advisory Council room, but rather the people that Jessica deals with out there in the local community, because we want it to be a conversation where there's no feeling of the consumers being overwhelmed by the power brokers, for want of a better term. So these are the same meetings I talked about before. And if you want to call that number, maybe they'll tell you they don't want you to come, or they may tell you to come. I really don't know. I'm going to call and see if I can come, and I'm prepared to say, no, we don't need you.
Question.
Hi, I'm Karen Levy with Linn, Benton Health Equity Alliance, and so much of the work that you're doing really is innovative and transformative, and a lot of it's happening at a pretty high esoteric level. Dr. Eby alluded to some of the pilot projects and said he didn't have time to talk about them, but that was where I kind of wanted to draw some of the focus back to is what are some of the sort of out-of-the-box thinking or out-of-the-box ideas that you think have worked really well? And looking forward, how do we take some of those pilot projects that are successful or some of the other innovative ideas and implement them so that they're really impacting OHP members in a day-to-day basis, you know, in their real lives? So I know the high-level systems transformation change is really important, and that will eventually impact people, but what do you see as, in the future, some things that are, that if you're an OHP member, you will say, today, my day and my health and my life are better because IHN CCO is working for me?
Okay, this was a test, right? No, so I think that there are a number of them, and we have a summary of them. A lot of them are in our transformation plan that was just sent back out. It's a great question, and it's one that the Community Advisory Council has actually also recently asked, and one that we have managed to get into place a really good evaluation process. Because I'll be honest, I think that's one of the challenges. We've had a lot of these great pilots, we've had a lot of energy around them and a lot of ideas, and now we have to figure out which ones are working, are they meeting our goals or our outcomes, are they sustainable, are they replicable? And so we have a process in place now, just starting in the beginning of this year, to do all those pieces, and the Community Advisory Council is asking the same thing, and we're going to be giving them an update on 2 of the pilots. I mean, one was around mental health literacy that we're going to talk around understanding and trying to work on diminishing the fears or the barriers around mental health issues so that we can work on them as a community. So that's just a simple example. But those are all out there detailed, and I think time will tell, to answer your question, Karen, around the longevity and which ones work, and that's why they're pilots, right, to see do they work. And we've had some that haven't worked, right? We've had some that started in the beginning, they didn't really meet the goal that we wanted, so we've tried a different angle now. And I think it's a sort of ties in with Stretch's question, right, around what have we done and where is it concrete. And I think there are some that are very concrete and doing very well and moving forward, and then the challenge will be how are they sustainable going forward to change the delivery system. But they are out there. I can't speak to them right off the top of my head in terms of the specifics.
It was less a quiz, Kelly, on what are the specifics of the pilot project, but really more about what is IHN's commitment to dedicating funding to some of those pilot projects that are successful.
Right, and I think that so the initial funding was there in the first 2 years, and we as an organization have been able to do some dedicated funding going forward as well in the next coming couple of years. So that's where we're going to be able to use our energy to see what's working and what's not working. And again, part of the pilots are that they need to be sustainable without necessarily that startup funding. So that really falls upon not the CCO, but really the community who's doing a lot of the delivery, and whatever we can help support and spring and grow. And part of it's us, but part of it's the delivery system to change how they're doing whatever they're doing to be different. And that's the challenging part, right? Because the seed money's there, but it has to keep going because the seed money won't be there. But we do have that going forward for the short term. Frank.
Well, I can give an example of an effort. I don't see a mic, but it's over there. I mean, I can give an example of an effort that reflects both of those issues. One has to do with, in my mind, a conversation and what Dr. Mullins mentioned earlier, which is whether it's directly or indirectly related to the CCO in Linn County, and I think the relationship occurred because of the CCO. It's probably been 2 years ago that Dr. Mullins and I had a conversation about mental health first aid. Since then, although it's not specifically done with CCO specifically targeted incentivized funding, it's been done with capitation on the part of at least Benton and Linn counties at this point. We have conducted, since May of last year, we have trained over 300 community members in Linn County with the support of the CCO in the latitude for Linn and Benton counties to use capitation, which is money to provide those kind of services, and on top of that, support from the Mullins Foundation to support that at that level. That is a stigma-busting piece and normalizing the issues of mental health and mental illness that have never occurred in my career, which started in 1974. It's the first true effort that blends prevention with mental health and mental illness. That's never existed in this state. So I think we've leveraged a lot of concrete results. I had a meeting today. We're in the process of talking about regionalizing the effort and capitalizing on the strengths of Samaritan, the Mullins Foundation, Benton County, and Linn County to be able to roll that out in a way that will be sustainable. So is it going directly to OHP members? I'd say probably at least half of it is. We've trained DHS staff. We trained staff. We're in the process of setting up a training with InReach, with the people that Mao served. Who may not be OHP, but my belief is will be at OHP, and to some extent, those kind of trainings and the people serving people at InReach help stabilize that population so we can get them enrolled in the CCO. So I think, I could probably give you a half a dozen places where we have concrete benefits and results that would not have come about without the partnership that we have with our coordinated care organization.
They seem to remember that there were a number of benchmarks that have set forth each of the CCOs throughout the state. And that after a period of time, I don't remember if it was a year or two, all the CCOs were supposed to achieve these benchmarks. IHN CCO, if I remember, I was one of the 4 or 5 CCOs that did not meet all those benchmarks and therefore did not receive what Kelly referred to as financial gain. My question is, what is IHN CCO doing so that they can meet those benchmarks in the future?
So I'm going to put Dr. Yuan Chin on the spot because he's here, and he leads our quality management committee. And you're correct. In the first year of the metrics, we did not make the minimum to get the full max. We did not meet the minimum amount of metrics to get the maximum dollars back. And again, I presented that to the Community Advisory Council, and Dr. Yuan Chin leads our quality management committee, and we've had a very different focus related to those metrics this year. And I would ask him to speak to those, if you don't mind.
So thank you for the question, because it's a really important one for all of us to recognize and understand that in the attaining of quality metrics and benchmarks, much of it really depends on the proper documentation and where you document this service and how it's being delivered. And when we looked at the different metrics that we were either achieving or not achieving, we actually found that we missed one of them by a small percentage. But because close is not close enough in the eyes of the state and meeting these benchmarks, we then lost out on the full amount of the incentive money. So what we do on a monthly basis is all of the quality people from all the CCOs in the state of Oregon have monthly meetings where we try to share best practices, learn from other CCOs that did meet these benchmarks so that we can bring home those ideas and thoughts to implement at our home CCO. So we don't know how we did last year. We're waiting for that information from the state, but it's my intent and the collective intent of IHN CCO that each year we build upon the successes that we had from previous metrics, and we try to meet even more of those metrics every year. The biggest challenge is documentation and how the state receives that information from all of the CCOs. We're not completely alone in that challenge of the documentation of the care. That's why we work hard with our colleagues, our primary care physicians, and how they document their services in an electronic medical record, how that then flows to what's called an encounter, and then how that flows to the state so that we can then further report on it. A lot of good work is happening, still more work that can be done. But we share those best practices from across the whole state in these transformation meetings, and hopefully we'll find out in the next few weeks how we did from our 2014 metrics.
Okay, 5 more minutes. A few more questions.
Just wondering if, as I said a little earlier, almost a year and a half into this window, and with the clear expansion of enrollment figures in the Oregon Health Plan in our Tri-County region here. And if I'm not mistaken, Kelly, isn't it something in the realm of 60 to 70,000 newly enrolled Oregon Health Plan members in our region?
Not newly, total.
Total.
So about 20 new since the expansion happened, 20,000 new for a total of about 60,000 people are on IHN CCO.
Across the 3 counties?
Across the 3 counties.
Okay. So we have added, tens of thousands of new people to the system in just the last, 15 months or so. And I'm wondering if you feel like you're in any kind of position to be able to assess or determine how your existing network of providers is doing at accommodating all these tens of thousands of new people. Maybe there are certain parts or, certain regions within the Tri-County region that are having greater difficulties than others. Maybe there's certain specialty areas in the field of medicine that are you may be noticing some shortages. I'm hearing anecdotally that people are feeling like when they call to schedule appointments to see their doctors, it's taking longer and longer to get an appointment, 2-3 months out in some cases. And I'm just kind of curious how you're feeling about the existing capacities of the network of providers that you do have.
So I'm not going to lie, that's a challenge. That's been a challenge for sure. I think one of the way we've been working to address that is related to the pilots and the alternative payment methodologies that you heard Commissioner Dixon speak to briefly. What we're trying to do with those transformation dollars is change the delivery model so that it can accommodate all those people and do what it needs to do in a different way so that it works better. And again, that doesn't happen overnight, and it certainly continues to be a challenge. And I think that the collaboration and the transparency and the communication amongst all the stakeholders has really helped, where we're able to really get together. If we have an emergent need that has to be addressed, we're all on it, and we can make that happen. That doesn't solve the problem, but it addresses that end of the spectrum. And it's a constant discussion that we have. I know that it happens at the provider level, at the plan level, and at the county level. What can we all do, and how do we get more providers? I think the medical school is one of the pieces that are part of the puzzle, recruiting people to our service area. And so all of those pieces are playing in, but it does continue to be a challenge that we do monitor very regularly and do what we can to help facilitate that, on top of working on all those transformation pieces that long-term will hopefully address some of that issue.
So let me try to speak to some of the things that we are planning and are doing right now that will help to address it going forward. But like Kelly just said, we got really challenged with the large numbers that we added to the plan here this past year, because obviously we didn't multiply the number of providers in our service area by that magnitude. So if we had a 10-20% increase, we certainly didn't have 10 or 20% more practitioners available to us to care for them. But in the context that the model that we're building for IHN CCO is in large part going to be the model of the future as we go forward. We're starting to evaluate some systems that will be available to the IHN patients as well as the general population patients to help address the provider issues. So like one example would be at the Samaritan Athletic Medicine Center. That's our new sports medicine center that's over at Oregon State University on the campus there. Well, we know a lot of people are thinking, well, I'm not an athlete. What good does that do for us? But indeed, our sports medicine physicians, our primary care doctors that have additional training in the musculoskeletal issues, sprains, bruises, contusions, whatever it might be. While there's a definite waiting period to get in to see an orthopedic surgeon, there's not necessarily a waiting period to get in to see those doctors. So like if the plan authorizes it, and I honestly don't know if the plan's contracted with them, okay. So if the plan has them as a participating member, anybody with a musculoskeletal type injury can be seen by those doctors usually in a day or two. I mean, access is that quick to care because of the numbers of them that we have available there. They can then make a decision about, do you really need to see an orthopedic surgeon tomorrow? Or can it realistically wait a month or two, or the things we can do in the meantime that will help that patient get better. So it's a different delivery model, but that's one quick example, is that we've committed significant resources to say, here's a group of doctors and providers that are specialized in musculoskeletal type issues. So it's not just for the football stars, it's for the general population. That's one example. Another is that we're looking at some technologies that I hope we can make available to the general population and certainly the IHN population that would allow you to access a primary care physician digitally or electronically through either a cell phone type opportunity or computer. And the studies are telling us that about 40% of the time, many of the things that we might go to our primary care doctors for, a sore throat, a fever, I don't feel good, or whatever it might be, can legitimately be handled over the phone or over the computer with them. So we're looking at some templates right now. In fact, I think we have our rollout coming out here in the next month or so that will be made available to people. And obviously, if we're going to say, here's how you contact your provider, they're going to have the device, so whether it's the iPhone or whatever it is, to contact them when they want to do an office visit. Now, there's a couple of reasons why we're doing that. One is that this type of a visit to a doctor can be done in about 1/4 the time. So instead of you going to the doctor's office and then you're waiting in the waiting room and the doctor's trying to get you in there, if he can actually have that encounter with you, whether it's virtually over the computer or over the phone, and take an appropriate course of action, whether it's prescribing a medication or telling you to come into the office or whatever, that's good for everybody. Patient gets cared for faster. It's a lower cost option for the patient, the doctor, and the system, and we can see more patients that way. Because the reality is that there's not enough physicians out there, no matter what we do, to handle the increased demand that's been put upon us with the expansion of these plants. So we literally have to change the patient model. So we're looking at how to change that model, both in terms of pilot projects for different practices, where you might be seen by people other than just physicians. You might be seen by a team, or you might have ongoing care provided by specialists in counseling services or things of that nature, so that we can really get the maximum benefit from our doctors when we need to have our doctors. But if technology and other resources can help us care for the people, we're smart to do that. Now the last point about the doctors, this coming June 5th or 6th, we'll add 100 and some new doctors to this community. That's our first graduating class from the medical school. Now, that's a big deal. That took about 6 years to get it to this point. The doctors have been in training for about 4 years. It took us 2 years before that to put the plan together to say, let's build the school, let's get them up here. That almost doubles the number of physicians in the state of Oregon in one day than what we had the previous day. Now then you got to get those doctors out of the medical school, you got to get them into the different training programs. So going back to the earlier question, well, what's happening, what are we doing? We're doing a lot, and it's starting to produce some results. But in a complex field like healthcare or medicine, it takes time to get it done, because we can't just make a doctor. It doesn't happen that way. But the good news is this June, we will have our first real graduating class of physicians. That is such a remarkable event if you consider the fact that we literally in the state of Oregon will almost double the number of doctors available to us to then train so that we can get them out in the field 3 to 5 years later. Now, in concert with that, to give you a little more background, we have about 75 residents that are going through training at the same time. And good news, particularly for our folks that are interested in behavioral health, mental health, a large number of those residents are psychiatric residents for mental health purposes. Now, 5 years ago, 10 years ago, none of that existed. So we're making good progress, and I think there's things we can point to, and the CCO can definitely be helpful in that regard if the CCO takes advantage of those things. Now, that's a decision they have to make, but I'd say, you know what, if I had a musculoskeletal type issue, and I was a member of the plan, and I tried to get access to the orthopedic surgeon, and it's gonna be 6 weeks before I can go see my orthopedic surgeon. I think I'd be at the sports medicine center. And I'd be having one of those doctors evaluate me to say, hey, is there something, you know, I can do? Now, when I get asked the question, well, would I do that? I've done that. And so I think, again, we're building a model for the entire population, not just for one segment. And that should make all of you feel very good, because we're building the best model for everyone, not just for a limited few. And so that's where I think we're gonna get the greatest benefit.
Great. Well, on that note, we are out of time, but I wanted to thank everybody for coming. I do have my follow-ups for Betty, I won't forget, and I'll make sure we get those for you. And again, we really appreciate everybody coming. If you have interest in being involved more, especially as it relates to our community advisory committees, see Dr. Eby or anybody who's got their little name tag on. If you want more information, we're always interested in making sure we get more feedback. So thank you everybody for coming, and have a lovely evening.